this is Well Woman Today. I'm Tamara Thomas, editor-in-chief of Well Woman Today, and I'm speaking with Dr. Bruce Dorr, board-certified OBGYN and subspecialty boarded urogynecology and reconstructive pelvic surgery, as well as senior medical advisor at BioTe. He's here to talk about menopausal women who possess the BRCA gene and what they should know regarding hormone replacement therapy. Thanks for talking with me today, Dr. Dorr.
It is a sincere honor. Thanks so much, Tamara.
It's fantastic having you here. All right, let's get started. So please talk about your background and your work with BioTe.
I delivered a ton of babies in my career. I started out as a general OBGYN, and I was on faculty at the University of Colorado Health Sciences Center here in Denver, Colorado. And with my experience, I grandfathered in to be subspecialty boarded in UroGyn. I was a great physician. I helped many women through reconstructive surgery, certainly pain and problems that they experienced. And I was there before hormones became somewhat evil and slanted. My cupboards were full of hormone replacement therapy. And then when the WHI came out in 2002 and hormones were bad, women got the short end of the deal. And I then went into further education and was exposed to BioTe. BioTe is a hormone education and marketing company, and it furthered my education in hormones pretty much across the board. I had a couple patients that taught me I wasn't doing a very good job, and I needed to be better when it came to perimenopause, menopause, and everything surrounding that. And as I grew and developed in that field, it pushed me more towards a functional medicine or a root cause or root medicine basis for disease. And I just never thought my life would be this. And BioTe certainly helped me in developing many tools in my toolkit to be able to help women and now their husbands and their men and their families, their children, kind of across the board. It is a very rewarding thing that I do on a daily basis.
That's fantastic. Can you give an overview of the common hormonal changes women experience during perimenopause and menopause?
I say this every day. There is nothing fair about being a woman. Us guys got it lucky. And so what happens before menopause, and menopause is defined by 12 months of no menses or periods in a normal cycling woman or normal menstruating woman. Up to 7 to 10 years prior to that final menstrual period is the perimenopause. And so the normal balance, the normal song and dance that goes on with ovulation and estrogen that builds the lining of the uterus and helps with over 200 different receptors all throughout the body. And then ovulation occurs, and the cyst that's made after ovulation makes estrogen's counter hormone progesterone that matures the lining of the uterus, and then withdrawal causes bleeding. Well, that song and dance, that balance between estrogen and progesterone starts to become out of sync, and it becomes a roller coaster of bleeding and symptoms and problems that happen kind of body wide for these patients, including risk for cancer and those kind of things going on. And unfortunately, it happens at the exact same time that many women are experiencing adult children, including their husband, that is, a challenge in their environment. And that's also coming at a time that, as a compensation, people aren't very good with diet and exercise because they're so caught up in trying to be everything to everybody, their careers, their children, their lives. And it is a very hard time for women.
That's the truth, Ruth. What
Yep.
are some of the conventional hormone replacement therapies currently recommended to manage menopausal symptoms?
Yes. So when we look at what's missing, you start to become in early perimenopause estrogen dominant. So women start to become not great at making progesterone, either the amount of it or at all. And so that estrogen dominance leads to headaches and nausea and weight gain and breast tenderness. And then later, as they approach that time when menses stop altogether, estrogen famine starts coming into play. So, night sweats and skin changes and joint pain and problems sleeping and vaginal dryness or sexual dysfunction. So, when we look at an early perimenopausal patient, it's more progesterone and to help them with bleeding and cycles and the estrogen dominance. You still keep on with that progesterone help, but towards menopause or late perimenopause, then they need help with estrogen and replacing that. And the whole key is if you put back into the body what's meant to be there, rather than pharmaceutical things that can have negative side effects. So there's differences between medicines that are the same and medicines that are similar. When you look at negatives and say like the WHI that I talked about earlier on, as far as Premarin, it was numerous different horse urine estrogens. None of them were meant to be in women's bodies. And so when you do something that's similar, the body can react in negative ways. It can react in positive ways also. But if you put the same stuff back into the body, we don't see negative reactions. You have to be careful on how you get it there. You have to be careful in the dose. And so that is the balance that goes on. And that's kind of the traditional method is those that are going on. Are there risks that are involved with that? Yeah. So you've got to be good at what that is. In general, women and men, we weren't meant to outlive our hormones. It's a relatively new thing, like from the
Mhm.
1800s and beyond. I was meant to die trying to kill a buffalo to feed my family, or whatever. And women were meant to die in childbirth or whatever related issues. So it wasn't until the 1800s that women really started living longer than their hormones. And so that's when menopause therapy started coming into play. And that's when these issues, and certainly today, we're living in longer and longer and longer. So
Right.
we're outliving our hormones.
That's an interesting way of looking at it, outliving
Yep.
our hormones.
Yep.
In your experience, how do you customize these therapies based on a patient's unique symptoms and medical history? And when is HRT not indicated?
Right. You have to look and live in your patient's space. What can they do? So if they just do something that they can't incorporate into their lives. Say they don't want to take a pill every day. Say they can't remember to do a cream every day. Many of traditional therapies only carry about a 10 to 20% compliance rate. So people give up. They get fatigued by doing these things going on. And so, are there other things that make it easier and easier to incorporate into their lives? And what are they comfortable with? If they think every time they're taking estrogen, they're going to get breast cancer like their mother, then they're not going to be on board with that. So then you need to look at alternative therapies or other ways to help them through that journey. There are contraindications to putting hormones in your body. If you have a hormone sensitive cancer, 80% of breast cancers are estrogen and progesterone receptor positive, meaning that if they have that and they take that, it makes the cancer grow. Estrogen and progesterone don't cause cancer. If estrogen caused cancer, women make a ton of estrogen during pregnancy. So you would think that when women don't have estrogen, then if that was the case in menopause, they wouldn't get cancer, but it's menopause women who get cancers. Women in pregnancy, they don't get cancer. So it's once cancer develops, that's when that cancer wants to grow and take over its host. And so that's when it develops receptors to those going on. There are other problems, meningiomas. There are people who have had a history of blood clots or things like that, that it's a contraindication depending on how you're delivering the hormones and which hormones you're talking about specifically.
I was going to say, I have a hard time believing that someone who seeks out hormone replacement therapy would then not follow up and take it. I think that it's doctors that tell patients that, well, you have to be concerned about estrogen. I don't know that patients necessarily worry about that on their
Yeah.
own.
Yeah.
But but why do you think doctors tell patients that?
So the WHI, let's talk about that for a minute. The
Right.
Women's Health Initiative, it
Mhm.
was one of the largest randomized controlled trials that started in the mid to late 90s, and it cost $1 billion. And that
Mm.
was the makers of Premarin and Provera. And they studied over 80,000 women between the randomized groups, women that had a uterus, women that didn't have a uterus, women that went to the placebo arm, and women that got the therapy. And the problem that happened is that women who had been on and taking hormones,
Right.
and that group of women, so there was a larger group of women that didn't take hormones and they went into the study. That group of women didn't have an increased risk of breast cancer. The women that were on hormones, they randomized either to take in Premarin and Provera, these are women with a uterus, or they randomized to placebo. The problem is women that took hormones had a decreased risk of breast cancer. It wasn't statistically significant, but then the that arm of the trial, the women that took hormones versus the women that had been on hormones and stopped them, it showed a difference because the women who were on hormones and stopped them had a decreased risk of breast cancer, and it made the women who then took the hormones look like they had an increased risk of breast cancer relative to that. Hopefully that kind of makes sense. But the women who had never been on hormones and they went on the Premarin and the Provera had no increased risk of breast cancer. But the study was stopped because of this difference that went on in the previous users of hormones because of this delta or the difference,
Mhm.
because women that took hormones had a decreased risk of breast cancer. And so it skewed the placebo group. Women who didn't take the progestin, women who just took estrogen alone, if you had a hysterectomy, you don't need the progestin part. They had a decreased risk of breast cancer. And when we follow these people up 20 years later, 22% decreased risk of breast cancer, 44% decreased risk of dying of breast cancer. But the study was stopped because of this difference. And so it not only scared women off of hormones, it scared providers. It scared doctors and nurse practitioners and physician
Mm.
assistant to the point. And when these other studies, the 20-year follow-up that said there was this 22% decreased risk of breast cancer and a 44% decreased risk of breast cancer mortality, that doesn't sell the New York Times. That doesn't
Wow.
sell the Wall Street Journal. When you tell women who are all on this drug, oh my gosh, you're going to get breast cancer, everybody listens, and then they all buy the Wall Street Journal. But if it's positive that hormones are good and can help you not only with your how you feel and your sex life, but it helps with your heart and it helps with your bones and those kind of things, that is not positive press. And so that doesn't get pushed, one, to the public, but two, to the medical community in general. So it's a matter, and I keep, you know, beating my fist over and over again. Don't be afraid of hormones. There's data skewed because, there's hormone haters out there, and they use things to sway people that hormones are bad. Hormones are not bad. They're meant to be a part of us.
Thank you so much for saying that and explaining that. How does carrying a mutation like BRCA1, BRCA2, or PTEN affect your clinical decision-making process for prescribing hormone replacement therapy?
Right. That's a scary thing for women. Breast cancer is scary. There's
Mm.
no way around it because everybody's got a story of their friend or a young person that is dying or got breast cancer. When you look at equal statistics, there are as many women dying of breast cancer a year as an osteoporotic fracture, but because it's kind of expected in women that are, say, 80 or later in life, it's not as tragic. And I'm not saying that breast cancer is not tragic. I'm just saying it's much more out there and in the press as we look at that. And when you look at a BRCA gene,
Mhm.
very few people carry these genes. Many more women are negative on these high risk problems related to BRCA genes. These BRCA genes are things you inherit from your mom or your dad. And so they are mutations. So we are full of messengers, estrogen, progesterone, testosterone. These are all messengers. They have to get to receptors in all of our cells, all over our bodies to click in, and then magic starts to happen. In BRCA patients, there's a problem with the receptor for progesterone. There are alpha or alpha receptors to progesterone in the breast, and there are beta or beneficial progesterone receptors in the breast. The BRCA gene patients miss the beta beneficial receptors in the breast. So when progesterone hits these beta receptors, it cools off and decreases the alpha receptors, which are awful and proliferate breast tissue. So when you don't have a beneficial effect to the breast, then it increases the risk. And these alpha awful estrogen receptors are on fire. And so women that have these BRCA genes get breast cancer early, not only to the breast. Most women don't die of breast cancer. Women die of ovarian cancer, and there's up to a 40% risk associated with BRCA genes of ovarian cancer. So once they're done having kids, then you got to get those ovaries out because that just comes up and they die a majority of the time, depending on the stage, which frequently is stage 3 out of 4 stages with ovarian cancer. With the excellent people in the field of breast cancer, women don't die of breast cancer. They die of ovarian cancer. So you've got to be very careful and screen these women very closely. You need to know what you're doing with a breast cancer antigen gene. And it's not just BRCA. There are over 20 different genes now that carry varying risks of breast cancer or gynecology related cancers.
Yeah, my girlfriend, she was diagnosed with breast cancer. She had the ATM gene.
I'm going to my ATM all the time and I get 20 bucks, almost every day. I think I must have that gene too.
So it turned out that the ATM gene was sensitive to all the mammograms that she was getting, all the radiation. And so that's actually stoked her breast cancer because what happened is they moved her from annual to 6 months to 3 months. So now she's getting these mammograms much more frequently. And essentially they were, when they found that they were like kind of like, oops, sorry, we didn't mean to do that. But
Yep.
she's cancer free now, but
Good.
that was sort of her journey. So do any of the hormone sensitive cancers concern you in this patient population?
Oh, well, sure. Sure. Breast cancer being the most common
Mhm.
cancer. So, over 400,000 women every year are diagnosed with breast cancer. But a majority of those don't die. And as long as they're getting screening, you pick that up early. So when women get mammograms starting at age 40, you decrease the risk of of dying from breast cancer by over 75%. So picking things up early and screening, yeah, it's a hassle, it's uncomfortable, but it can save your life. So, and if you have one of the cancer antigen genes, usually those women are going to MRI screening to avoid the frequent radiation that can come with more frequent mammograms. So I'm sorry about your friend. The other things, there are other hormonally sensitive cancers out there, certainly gynecology cancers. There are brain cancers, there are skin cancers that are estrogen receptor fed. Estrogen doesn't cause them, but once it's there, cancer wants to live, take over its host, and take over. So you have to be careful once it's there.
Why do you think there are so many young people now, under the age of 50, under the age of 40, that are developing cancers? Why do you think that is?
Well, we live in the best time ever as far as our food supply, how we're living. I look at how we live in America, it's pretty good. But are we now exposing ourselves to many things because of our lives and our lifestyle? There is now an acceptable amount of Roundup or glyphosate in our bodies. There's acceptable amounts of microplastics now in our bodies, in our brains, in our blood vessels. There are things that we're exposed to. The human body, I think, is pretty good. It's pretty adaptable. But there is what we call the allostatic load, the amount of negative things that are hitting our bodies when I put on my deodorant or when I put on, I slap on a little, Jovan Musk. I think it's a good thing, but, you put on these chemicals on your body. I'm kidding. So you put these chemicals on your body and stuff gets in your body that shouldn't be there. How your body then reacts is a problem. And we are doing these things to our body. And I look at how I grew up, and both my parents were raised on a farm, kind of organically, great soil, and that's what we ate and fed, and I had fresh vegetables and fresh fruit and unadulterated packaged meat. And I look at how I raise my kids, and I would go, and it's convenient to get the kids' meals and French fries and mac and cheese and those kind of things. So when we look at what we're putting in our bodies, it's not as nutrient dense, and all that
Mm-mm.
nutrient dense material is anti-cancer. And so, and plus, I think we're better at screening. I think we know and we can pick up stuff earlier and earlier. I'm going to deviate for a minute, but there are now blood cancer, they call them liquid biopsies, but there are blood cancer tests, for, a little over $900. You can pick up when cancer's in your body, it starts breaking down in little pieces of these cancer particles are found in your blood. And so you can pick up 50 different cancers just doing a blood test. It can tell you got cancer in your body, and it can tell you which one for $900. So are we better at picking stuff up in our environment? Yes. And is our environment toxic to us? Yes. And is things that are out there that are meant for profit, not for our health, killing us? Not overtly, but slowly? Yes, in my opinion.
Hmm. I
I'm not
thought,
Mr. Doom and Gloom. I'm pretty happy in general, but there's stuff that's out there that's hurting us.
oh yeah, I thought I heard you say that might have been a mistake that processed food was anti-cancer.
Nope.
That was
So nutrient dense food is anti-cancer.
right,
The
nutrient dense. Okay.
processed food is hurting us or killing us. It's
Okay, I just
killing.
wanted to go over that because
Yep, yep. Sorry if I
yeah.
said that wrong.
Oh no, no, it's okay. So if
Yep.
a high-risk patient wants HRT despite the risk, do you give it to them? Do you use monitoring protocols for potential cancer, or do you politely decline to treat the patient?
I never decline, concerns that my patients have. You have to live in that patient's space.
Mm.
And I counsel on the risks and benefits, and it's a shared decision made between myself and my patients. There are certain things that draw the line. You got a breast cancer, I see, so many of my patients, they're like, hey, you need to see my husband because, he's my biggest sexual problem, or he's my biggest problem in general. So I've become a gynecologist. So I see many men now on a regular basis. But when I talk to my patients, anything that you do in medicine carries a risk and a benefit.
Right.
Is the benefit and where I'm sitting with this patient? Because when a patient gets breast cancer, one, they're scared. Two, they're scared it's going to come back again, and they're scared it's going to kill them because many of these women, they immediately go to, my kids are not going to have a mother. There are so many things that women want to be everything for everybody. I kind of said it in my initial thoughts,
Yes, you did.
that there's these pressures that, oh my gosh, I can't die. And so what do? They suffer, with these menopausal symptoms. They go to these dark places. And so what do I do for them? Okay, are you cured of your cancer? Can I do testosterone rather than estrogen and progesterone? Can we do other or alternative therapies? Did you have a stage 0, a precancer, and somebody fed you that this was actually cancer, and say you had a double mastectomy? Say you got a prophylactic, you had your ovaries out because of your BRCA or whatever, and you had your breasts removed. Because I get people, they get in that boat, just like I was saying, they're scared. They're like, take everything, you know? And so then they live, in this kind of shell of no hormones, and they go to very dark places. And there's a little bit of a risk when we look at traditional hormone replacement therapy, but it's a very low risk. What is a bigger risk? Dying of heart disease, dying of osteoporosis, dying of early dementia. So you have to look at what is the biggest risk for this patient, and can they then, if they're living in this bad space, maintain their relationships with their husbands, with their children. So you have to figure out what's acceptable, what's not, what's a risk, what's a benefit. And yeah, I have many patients who they've been cured of their breast cancer, and we talk hormones. Could it be just testosterone that's not breast cancer necessarily fed, or that we don't know? It's a gray area, or I go over diet and exercise.
Okay, so I'm not talking, obviously it's a little bit, trickier for
Yep.
someone who's had a cancer diagnosis.
Yeah.
But
Yeah.
let's say you're just a gene mutation carrier.
Yep.
You just carry the gene. You've never been diagnosed with cancer.
Yep.
Let's say, or add to that, maybe the person underwent the prophylactic procedures that you just talked about.
Yeah.
Are you comfortable in that scenario prescribing HRT for
Yep.
mutation carriers?
Yeah. So the organs that would get cancer are gone. So, okay, you can never say never and always when we look at breast cancer if they've had a prophylactic mastectomy. That risk
Right.
is less than 1%.
Right.
So, what are they much more likely to die of? They're much more likely to die of heart disease. When you look at the risk of women dying, heart disease is by far and away number one, and that is number one by the next 10 diagnoses combined. And when we look at estrogen replacement therapy in a woman that's undergone premature removal of her ovaries and premature loss of her ovaries, she is increasing her risk significantly. One, of dying of heart, brain, and bone problems. But if I put her on estrogen, I can decrease that risk by over 50%. There's nothing else that does that. Certainly, diet and exercise help. But in many large observational trials, women, if they take estrogen within 10 years of menopause, or under age 60 naturally, or when they've undergone surgical menopause, like these patients, you can prevent heart disease and certainly bone disease and osteoporosis.
What about a patient who did not give up her ovaries? Maybe she gave up her fallopian tubes instead. Does that change the calculus?
Uh, so you decrease the risk of ovarian cancer by removing those tubes. We know in a study, it's over 10 years now, that 20% of ovarian cancer can actually come from the fallopian tube. There's a few studies out now that say, is that 100% true? I can't 100% say that. But there's never a case with a surgeon with a BRCA positive patient that just would remove the tubes and not the ovaries, because those ovaries are going to kill them. So you monitor every 6 months with ultrasounds and blood tests on these patients who want to keep their ovaries until they're done with childbearing, and then you remove the ovaries. Do you need to remove the uterus? Not necessarily, but many women go for that because of bleeding things that can go on. So that's the standard of care when we look at a patient with a BRCA gene. And then if and when they're ready and they don't want to do continual monitoring, then you can do a prophylactic mastectomy. But otherwise, it's screening every 6 months on their ovaries, and blood tests, and ultrasounds, and then MRIs and mammograms.
Are there any alternative treatment options you would consider to treat menopause symptoms for patients at high genetic risk? Like what
Yeah.
lifestyle modifications would you advise?
Sure. Yeah. Diet and lifestyle. I know it's funny, but okay. A doctor recommending diet and lifestyle and nutrition. That yes. So that all affects. We're making cancer cells every single day. So when we put in our bodies things that are antioxidant, anti-cancer, those things help with that. When you're genetically predisposed and potentially, especially that progesterone and BRCA carriers, or you have to look at what these other things like ATM, what is it? What's that specific mutation that's going on? Yeah, you got to live in that patient space. People that are afraid of hormones and I can't talk them off of the ledge, there are other therapies out there. There is a relatively new drug called a neurokinin 3 receptor antagonist. There's this whole other thing that helps with vasomotor symptoms in the hypothalamus in the brain, in the kind of thermostat regulating center of the brain that can help. There are naturopathic things that also can maybe affect that level. There is a Swedish flower extract that I go to. There are other medicines that there's clonidine. There are other even blood pressure medicines that you can use to help these patients. So there's always something. I've got always a trick up my sleeve depending on where that patient is living and what they're willing to do. And I counsel them on that risk and benefit that goes on. Is that going to be enough for them? We try that and see if that's good enough for them.
What about emerging therapies or current clinical trials that look good for managing menopausal symptoms in high-risk patients?
Yeah, that I mentioned, the neurokinin 3 receptor antagonist, that is kind of the new frontier as we look as far as FDA approved drugs and therapies for this. I think to me, a new frontier is an old frontier. A new frontier to be educated on the risks and benefits of hormone replacement therapy and not to be scared and have and understand that education. And certainly testosterone. People are afraid of testosterone and they think that's a guy's hormone. No, that's very much a female hormone. And so to understand what that is and to hopefully have more trials on testosterone in women to validate that therapy other than what's currently out there is, in my mind, a great way to go. These other things, as far as monitoring, like I said, looking at these liquid biopsies, these blood tests that screen and look for cancers, and getting to people in early stages or early screening for diseases like that, I think is an awesome way to go.
Hmm. What advice would you give to clinicians who care for perimenopausal or menopausal patients with high-risk genetic mutations?
If you're not up on something, you're down on it. So you need to be educated on on hormone replacement and what's out there. If you can't take the time or the effort to do that and be knowledgeable for your patient, if you only have horse urine pills in your cupboard and that's what you're comfortable with, you need to get somebody who can be a bigger resource for that perimenopausal and menopausal patients. These people deserve an educated provider. And so that's where I sit certainly with BioTe is I do education every single day. And so to get the word out there on teaching everything, we're not just one thing. I teach people on all the different types of hormone replacement therapy and that going on. Resources like the Menopause Society, I think, is another great source. But to get them, if you're not comfortable, get them to people who are comfortable. And so don't just be one thing and one-sided for these patients because they deserve much more than that.
And so BioT specializes in bioidentical hormone replacement therapy.
It started out originally just as a pelleted hormone replacement therapy. It's a type of delivery system for
Mhm.
women, and certainly that's there. But there are many things that people are not comfortable with, whether or not that's related to cost or delivery. So it's the same premise that I follow when I look at root cause medicine, like Why do people get high blood pressure? Why do people get high cholesterol? Why do people, well, we all know why we lose our hormones because we're living longer. But when I look at replacement, there are many different things. But when we put back into our bodies the same thing, and ideally, if you deliver it in a similar manner, we don't see the risks that come with, say, pharmaceuticals or things that are similar to what was in our bodies. So those are the premises that I look after. And when I read studies, okay, how did they get it there? What were they using when studies start saying there's risks, going on related to hormone replacement therapy?
Dr. Bruce Dorr, thanks so much for your expertise, for your honesty, and for your time today. I really appreciate it.
Awesome. You are awesome too, Tamara.